Thank you so much, everyone, to come to our bi-weekly ID series. We are extremely excited today to have Dr. Collins from Temple to talk to us about the fascinating topic, Keep Safe and Smoke-Free. However, before I introduce Dr. Collins, I'd like to go over some housekeeping issues. So I'm sure you all know for CME credits, you now must take the CME office to receive credit. The activity ID today is 218. This is for both online and in-person viewers. Make sure you sign in and please RSVP so we can better prepare for the next session. We will return after Halloween, so we have a few weeks without any talks. So after Halloween weekend with a tech talk on November 3rd, when Paul Cole will feed our minds with using hurdle models to analyze zero-inflated count data. That will be very, very interesting. I can't wait. Really. And followed by an ID series presentation on November 11th with Dean Gaffney from Hopkins, who will speak on the impact of marketplace guides on healthcare utilization. And as always, please visit the ACCEL website at DE-CTR.org for the full schedule and recording of previous presentation, and it works very well. So Dr. Collins is currently Associate Professor in the Department of Public Health at Temple University, as well as faculty in the Cancer Prevention and Control Research Program at Fox Chase Center. And he has a very impressive CV that I had a very hard time to summarize in one page. He got his MA in Experimental Psychology at University of Hartford, a PhD in Clinical Psychology from Binghamton University, that's part of the State University of New York, and has had multiple honors over the years. For example, in 2003, he received a certificate of commendation from the Governor of Commonwealth of Pennsylvania for leadership in the development of the first state comprehensive cancer control plan. And more recently, in 2016, a Graduate Service Award for outstanding leadership in creating new graduate programs in the College of Public Health at Temple. Currently, he is a PI on 2 R1s related to tobacco cessation interventions and has completed numerous and multiple NIH and federal grants. Has a large, long list of publications. He's also an educator and mentor for a large number of undergraduate, graduate students, and postdoctoral fellows, and is also very active in the community. And also, he's been interviewed on TV and on the radio, mostly WHYY, and for Radio Times. I'm always very impressed by that. Very impressive. And the Health and Science Desk of WHYY. So thank you so much for giving us this presentation, and welcome.
Thank you very much. All right, I am certainly happy to be here. Thank you for having me. This is, I was mentioning, this is the first time that I've actually set foot in Newark. I've done a lot of traveling between Philadelphia and Washington, D.C. area where I grew up and where my parents still live. But it was nice to kind of get a lay of the land. You have a very nice campus. I'm going to talk a little bit today about some background related to tobacco-related health disparities, focusing on parental tobacco smoking and children's exposure to tobacco smoking. What some of the problems are in terms of health disparities related to this problem, and what's been done, what some of the gaps are in addressing this health disparity, and what colleagues and I have done over the last 4 or 5 years to address this problem. And I'm hoping we'll have time at the end to have some question and answers, but if you certainly have questions during the process of the presentation, don't hesitate to raise your hand. It's interesting because when I was putting these slides together, I had the presidential debate on in the background. I was thinking maybe there'd be some creative way to mix this up and have a good interactive session here. And then the more the debate went on and the more dejected I got about presidential politics, I decided just to stick with the normal format for today. But in any case, I hope you find this interesting and maybe have you consider how the type of approach that we've been implementing or testing for efficacy might relate to some of the work you're doing. First, I want to thank my co-authors and co-investigators. So Dr. Steve Lepore, who's a professor in my department at Temple University, is the co-PI on the project. I also have a couple of co-investigators, one who was a postdoc, Dr. Nair, when she started the project with me. Now she's an assistant professor at the University of Arizona and is a co-director of Arizona's Smokers Quit Line. And Adam Davey, who has now joined the University of Delaware recently as an associate dean for research. He's the project statistician in this work that I'm presenting. Melissa Godfrey, who's project coordinator, has worked with Steve and I for many, many years. And then Jonathan Winikoff, who is a pediatric consultant on this, consultant and co-investigator. He's at Mass General Hospital. And then we also had some site co-investigators where we engaged in clinic-level intervention. And these co-investigators served as clinic liaisons, but also informed the intervention design and implementation at the clinic level. And those include Beth Moan and David Fleece at Temple Pediatrics, Tyra Bryant-Stevens at Children's Hospital, and Dan Taylor at St. Christopher's Hospital. We also partnered with Sesame Street and used some of their health education focused on improving diet on a budget. Use those materials for our attention control condition in the clinical trial I'm presenting today. And the R01 was funded by the National Cancer Institute. I also want to say that I have no conflicts of interest. What I'm hoping that you guys get out of this presentation today, my objectives for what I'm presenting, I'm hoping that by the end you'll be able to identify and describe factors that are associated with tobacco use disorders. To be able to describe the shortcomings of existing evidence-based approaches to smoking cessation, particularly when you're targeting efforts low-income, racial minority populations that have greater challenges to smoking than the general. I'm also hoping you'll be able to contemplate the potential utility of multi-level intervention strategies like the one I'm presenting today, and can contemplate how that type of strategy might be able to be implemented in current clinical practice in a variety of ways, as well as inform future research. So, it's no news that smoking is hazardous to your health, and certainly over the last 15 to 20 years there's been growing evidence that exposure to secondhand smoke is also hazardous. There's more than 7,000 different constituents and chemicals in secondhand smoke. Hundreds of them are toxic, like some of the ones that you see here in this slide. And we know that about 70 cause cancer. Now, in particular, secondhand smoke exposure is dangerous to children, and there's an inverse relationship between age and the consequences associated with exposure to secondhand smoke. Younger children are more vulnerable to the consequences. And these include ear infections. Secondhand smoke is the leading cause of ear infections. It's a leading cause of upper and lower respiratory infections. It contributes to asthma and increases asthma severity. And it's also been attributed to sudden infant deaths. There's a lot of health-related consequences associated with children's exposure. Some of the consequences to adult exposure include cardiovascular diseases, stroke, as well as lung cancer. And since the mid-1960s Surgeon General's report, it's been estimated that about 2.5 million Americans have died as a result of these. So there's some pretty serious physical and health consequences associated with exposure. And I just want to point out, wherever you see anything in the slides where it says TSE, that's just an abbreviation to save space for tobacco smoke exposure. When we talk about tobacco smoke exposure now, you tend to hear that more so than secondhand smoke, even though that'll slip into my dialogue from here every now and then. But the reason why researchers and clinicians are describing tobacco smoke exposure, not secondhand smoke exposure, is because of evidence of third-hand smoke exposure. So how many of you have heard of the term third-hand smoke? how would you describe what third-hand smoke exposure is in the way you just discussed it?
The residue that you can bring in on your clothing when you pick up your newborn baby, and the baby's being exposed to it, even though you're not blowing the smoke in their face.
Right.
You still have the residue on your clothing and on your hands.
Perfect. Yeah. So secondhand smoke, we know, is the smoke that comes off the end of a burning cigarette, as well as what's exhaled by the smoker in the environment. Third-hand smoke is all the constituents in smoke, in the secondhand smoke, that settles on hard surfaces, as well as soft surfaces, clothing, hair, carpeting, upholstery, curtains. And the constituents that are in that smoke that settles can be re-emitted into the air, and children and adults can get exposed to that. And there's evidence that the re-emission of these constituents of third-hand smoke can occur days and sometimes even weeks after a cigarette has been extinguished. So I always think of times when I've either rented a car or walked into a hotel room that, even after I've requested non-smoking, of course, and you can tell immediately if somebody's smoking there, and they may not have smoked there within hours or even the previous night. It could be just many times that people have smoked. It could be a couple of days ago. But anyway, that's what you're detecting when you walk into a room like that is the third-hand smoke that's getting re-emitted as somebody walks across the carpeting. Imagine a cartoon, somebody walking across these little poops of smoke, because you don't see it. That's the problem. And then by the time the 2006 Surgeon General's report came out, there was enough evidence about the dangers of tobacco smoke exposure for him to declare at the time that there's no safe levels of exposure. So even detectable levels of exposure to relate to risk and consequences associated with that. There are also behavioral consequences to exposure. Probably the biggest consequence, although there's some serious consequences such as the association of tobacco smoke exposure to attention deficit disorder and neurocognitive deficit. But there's also concern because children who grow up in homes where there's a smoker are 3 times more likely to become smokers when they're in adolescence than children who grow up in non-smoking. I'm just glancing at the time, and I don't think I have time to show this video, but my understanding is that these slides will be available. So I encourage you to look. I don't know if anybody has seen this Indonesian child. This video, which is about a 5-minute clip, went viral a couple of years ago, and it shows I guess at the time he was about 2.5, 3 or 4 years old. But he started smoking when he was 18 months old. Like many smoking parents, he started smoking his first cigarettes that were offered by the parent. That often happens. And by the time this video was shot, he was smoking 4 packs of cigarettes a day, and he became a tourist attraction. It was really kind of sad to see the number of photographers and media that were there and just watching him smoke. And of course, no surprise, he would have temper tantrums when he didn't have cigarettes available because he was in withdrawal in between smoking 4 packs of cigarettes a day. So I encourage you to look at that. It just highlights very graphically the role that parental smoking has. And there's a couple of different reasons which I don't have time to go into, but children who are exposed to secondhand smoke, their neurotransmitter systems essentially are sensitized to smoking such that compared to a child that's rarely been exposed, a child that's grown up in a home where they've been exposed to secondhand smoke daily, when they smoke their first cigarette, they get more bang for their buck, so to speak, in terms of the reinforcement of nicotine. It feels much better. They get much more of a jolt than somebody who's rarely been exposed. You have these neurocognitive effects, the sensitization of just being around, but then you have all of the psychosocial and interpersonal factors such as modeling, parent modeling. Now, probably one of the most successful set of public health campaigns has been focused, the public health campaigns and the policies and legislation that is focused on protecting non-smokers from exposure in public places. And what this graph shows is from 1999 through 2012, the dramatic decrease in the percentage of non-smokers that are exposed. So this particular graph shows detectable levels of exposure as measured by serum cotinine, which is a biomarker for secondhand smoke exposure. And it shows that across the whole population, there's been a dramatic decrease, and this has been attributed to a lot of the restrictions in smoking in public places. Now, this looks really exciting. It's great, and we should be excited about it because there's a lot of positive lessons learned in terms of the successes of public campaigns addressing secondhand smoke exposure. However, an unforeseen consequence has been the increase in disparities of secondhand. So I'd like to take a second to look at this graph. What this graph shows is subgroups of non-smokers who are exposed to secondhand smoke daily. And this was taken from NIH data that was published in Homa and colleagues in 2015. And it shows that younger smoking Americans have higher rates of exposure. So children who are aged 3 to 11, at this point in time, 41% of them were exposed to secondhand smoke compared to older age children. Now, what would be some reasons why younger children are more likely to be exposed to secondhand smoke than older children?
Probably their environment that they're in, especially if they're preschool age, if they're even below preschool age, if they're in a home daycare setting. You know, if the child is of school age, I don't think that the teacher is going to be smoking in the classroom. So I think the environment that these kids are in at different ages.
Bingo, yeah. So the primary source of children's exposure to secondhand smoke is their parent. And if a child is living at home, like a preschool kid, they're spending more hours in the home. And also, the younger the child gets, the more dependent they are on the parents, to the point when you have an infant, you know, the smoking parent is handling the child. And so that's the biggest reason why you see young children being more vulnerable to exposure. But also, compared to other racial and ethnic groups, Black Americans have much higher rates of secondhand smoke exposure. And at this point in time, 47% of Black Americans, non-smokers, are exposed to secondhand. See a similar pattern in impoverished Americans. So American non-smokers who live below poverty have more than double the rates of exposure than people who live above the poverty line.
Excuse me, question there. What's the other missing 20% or something for the poverty level, or even 30% of the?
I'm sorry, which one?
You have 43% above, and then below, and at above 21%. What's the rest of the percentage goes?
Yeah, I think, so this particular chart doesn't break all of the subgroups down. So these are just the main subgroups. Frankly, it's been like 2 years since I was, but I'm pretty sure it didn't break down all of the ethnic groups.
Okay.
Yeah. Now this is a chart that drills down a little bit more specifically to children ages 3 to 11, so the most vulnerable children. And looking over time from 1999 to 2012, what we see is a pretty consistent decrease in Mexican Americans and white non-Hispanics, even though it's a little bit more jagged decrease for the Mexican Americans. But you see from 1999 to 2000 to 2011, 2012, there is a decrease. But when you look at Black children, that decrease, you don't really see much of a decrease. And this suggested that children aged 3 to 11, about 70% of them were exposed to secondhand smoke daily, compared to 30 to 40% in the other racial groups. Now, when it comes to trying to address these disparities, really, there's no better place, unfortunately. I guess fortunately for people that do this work, because we're able to try to figure out how to improve strategies to. There's no better place to do the work than Philadelphia. Philadelphia has the highest adult smoking prevalence than any of the other major U.S. cities. At this point in time, 2012, the smoking rates were about 25% in Philadelphia across all, the general population. It's decreased a bit since then, but again, the smoking rates have remained high in lower income folks. This particular slide illustrates the disparities in Philadelphia. So the red areas are where there are the highest smoke exposure rates. Now, specifically, this graph is showing the percent of homes where there's a smoker. So the rates look a little bit lower than the previous slides where we were looking at children, the percentage of children that were exposed. So given the fact that most families that live in low-income urban environments are living in multi-generational homes, and there's many children often living at home, that's why you see upwards of currently about 50% low-income African-American children are exposed. But some of you may be familiar with Philadelphia. Does anybody know where this section of town is, what this section would be called?
Center City, West Philly.
Any Philly people?
Center City, West Philly-ish.
I'm sorry?
Center City and West Philly.
Yeah, well, close. So this 2% section is Center City. Right above it would be considered part of North Philadelphia, pretty much where Temple University is. This section over here is West Philadelphia, and then this is Southwest Philadelphia. Now, what's interesting with this breakout of disparities with respect to the percentage of homes, if you were to overlay this with poverty or another graph of lifestyle-related chronic illnesses, it would look pretty much the same, where you have elevated risks, risky behaviors, and elevated diseases, prevalence of diseases in these sections. And what's interesting is Philadelphia really is, and I experienced this just working in this area. It's like the tale of two cities, because you have one of the poorest, the poorest area that has the highest smoking rates, butting up right against the more wealthy, healthier sections of town. It gives a stark contrast. And then just so you know, the partnering clinics that we worked with for this trial that I'm going to get to in a minute, were located in the highest smoking areas and the most impoverished communities. And we were able to get to the heart of the problem. So just a quick summary of what I've stated so far. There are a lot of risks associated with tobacco smoke exposure. And even though we've seen population-wide the rates of exposure decreasing over the last 10 to 15 years, tobacco smoke exposure remains high among young children and among blacks living in poverty. And Philadelphia has one of the highest smoking rates among all the major U.S. cities, and consequently has high rates of secondhand smoke exposure. So what has been done? I encourage you, if you're interested in this area, to read two meta-analyses that came out in 2012 and 2014 by the same team, Rosen and colleagues. They looked at two sets of intervention trials that have been conducted to address this problem. One set of trials focused on trying to get parents to quit smoking, and another set of trials focused simply on teaching parents to protect their children from secondhand smoke exposure. And the overarching take-home message was that even state-of-the-art interventions compared to either no treatment controls. The control groups included no treatment controls and some with attention control interventions. Really, there was just modest improvement. Kind of looking at their interpretation as well as looking through each of the individual studies, you begin to see a pattern that evolves in terms of the shortcomings and why state-of-the-art interventions are not getting the impact that the investigators are seeking. One is that there's inadequate access and support for smokers in distressed communities. Now, regardless of a person's background or their income, most smokers do want to quit. If you were to survey a group of smokers at any given time, the vast majority of them would say, yes, I want to quit. And then there's a lot of ambivalence about their readiness to quit or their competence. Most people do want to quit. The challenge with low-income smokers is that there's a lot of barriers to access. It's not that they don't have access or not that there's not efforts on our side to try to provide access to services. It's just there's a lot of nuisance barriers and challenges to accessing. So if you're trying to address this problem, you really need to try to break down those barriers. There's also lack of sufficient intensity for behavior change. So all of the vast majority of the studies that were in those two meta-analyses really used just brief advice. And when you're dealing with a population that has a lot of stress and a lot of challenges to behavior change, brief advice may just simply not be sufficient to promote behavior change and teach the skills that are necessary to change a chronic relapsing disorder like dependence. And then the other problem is when you just focus on brief advice, or some of these other studies just provided like group counseling or telephone counseling, those types of strategies are really focusing on a limited set of determinants of behavior change, or behavior and behavior change. So there's a lot of reasons or a lot of factors that influence why someone keeps smoking and their difficulty. There's determinants at the behavioral level. So based on learning theory, different people through the course of their dependence develop different cues or triggers that elicit urges to smoke that are idiographic or that are specific to them. There are biological determinants that maintain addiction. So people smoke to try to minimize the adverse experience of withdrawal symptoms. There's psychological determinants like motivation, psychiatric comorbidities like depression and anxiety, and different levels of confidence that can affect whether someone changes. And then, of course, there's social contingencies or social factors. If somebody lives with a smoker, there may be less support for quitting smoking, or maybe sabotage for someone's efforts in their smoking. So when interventions focus on just one level of influence, they're limiting their ability to address all of these myriad factors affecting smoking and the probability of behavior. Looking at the time, I have a few slides to talk about the theoretical framework for the interventions that I do. I just want to show you a couple of the slides, make reference to Mel Hovell's behavioral ecological model, and then just try to quickly summarize the relevance of this model. This model is based on more familiar social ecological models that look at multiple determinants of behavior, all the way from the most molecular, like genetics, all the way to the most broad, like political landscape and culture, and then everything in between, like interpersonal level factors. So kind of think of an onion where the core part of it is the individual level biological factors, and then all the layers that go around through social structures, family factors, community factors, all the way to the broadest factors. So you have all of these different factors, and where the behavioral ecological model is different is it uses principles of associative learning to describe how different contingencies or factors that affect behavior at one level can interact with factors that influence behavior at another level. So just keep that in mind, that you have these different levels of influence and certain things that can happen at one level influencing behavior that you could try to maximize that effect at a different level of influence. It's important when thinking of a multi-level intervention. I apologize, I don't have time to go more in depth with that, but I do have some slides that that highlight kind of the internal factors and the external factors. He calls them inside the skin and outside the skin. That all impinge on behavior at any one time. So if you're interested in theory and how to frame an intervention within theory, I encourage you to take a glance at these slides and look up Mel Hovell's work, which is referenced on a couple of these slides. So aside from the theoretical framework that can guide the intervention that I'm going to talk about, there's also empirical evidence that suggests that multi-level interventions can work. So there's evidence that shows that higher intensity multimodal interventions improve cessation outcomes. So simply not some written materials or here's an app that will help you quit smoking. It's trying to pull multimodal pieces together. And if you can, that's going to improve cessation outcomes. Also, trying to attempt to address multiple levels of influence are important. And there's evidence for that in other areas like diabetes, cardiovascular disease prevention. And the empirical data as well as the theoretical framework really guided our hypotheses, which was if we could combine a system-level pediatric clinic intervention with individual-level behavioral counseling, we might be able to get at different levels, different sets of determinants of behavior, and maximize the messaging, the health messaging, to promote motivation as well as skills to help parents quit smoking, children from second year. So what we did in the Kids Living Safe and Smoke-Free, or the KISS program, is we first focused on pediatric clinics and our partners. The idea for focusing on pediatric primary care was that they're at the front lines of this problem and are in communities where they can make a difference. And when a parent comes into a clinic, it's a teachable moment for them. And so it's reachable and teachable. It's an opportunity that we feel is important to take advantage of. And pediatric providers are highly credible sources of information. So they can motivate, boost motivation, or increase the will of parents to change. Where an individual tele-based counseling intervention is important is it can kind of piggyback on the increased motivation and provide individual level skills training to offer skills and coping strategies to help people through the process of smoking behavior change, which is beyond the capacity of 5 to 15 minute clinic visit. No matter how talented a pediatrician or a pediatric provider is, they just simply don't have the time or the resources to provide the level of skills training. So the trial was a 2-group randomized control design. We had the clinic level intervention that everybody got. So everybody, even prior to randomization, got this clinic level intervention. Then they were referred to our research office where we randomized them into the 2 groups. One was the experimental group where we, on top of the number 1 clinic level intervention, we added this individual level intervention that built on the messaging that they received from the pediatricians, versus a control condition where rather than getting intensive telephone intervention around smoking, we provided them with information from Sesame Street on nutrition on a budget. And we completed a 3-month assessment, which is the data I'm going to report today. And we just finished the 12-month assessment, which we haven't fully analyzed yet. So part of the clinic intervention was we would go in, work with our pediatric clinic liaisons and co-investigators to get a sense of what their current operations were for addressing child exposure, which was important because then from that information we were able to build a tailored intervention that would boost their adherence to the pediatric guidelines for addressing parental smoking. We plastered their clinics with posters and pamphlets and basically marketing of the intervention. It also included cues or prompts to the providers to follow the Ask, Advise, Refer guidelines. We also, as part of the intervention that the clinicians gave to the parents, they were to ask, advise, refer, and then provide a pamphlet from the EPA that outlines strategies for protecting your child from secondhand smoke. So keep in mind, everybody in both conditions are getting this information. We facilitated adherence to the guidelines by embedding prompts into the regular workflow in the electronic health record. So this is a snapshot of Children's Hospital's EPIC electronic health record that, I guess this is the point at which they are prompted with some advice that they can give, as well as after they ask if they want a referral to our program, then they tell them a couple of different things about what the program's about. And then if the parent's interested, then they press a button and we receive a fax referral on our end. I'm just moving forward because I see we have minutes. So the behavioral counseling component included cognitive behavioral therapy-based counseling or coaching, health education, and support from a trained telephone counselor. Participants received 5 proactive phone sessions and print materials over the course of the 3-month intervention window. The counselors also provided nicotine replacement therapy education and navigation. So in addition to training the pediatricians to encourage nicotine replacement products and even write prescriptions to parents for NRT, our counselors would follow that up with, so have you gotten your NRT? If you haven't, let me help you find where you can get it. So we knew where they live, and we would give them specific directions about where to go, how to get it. And if it wasn't immediately accessible, we would refer them to the Pennsylvania Quit line where they could get free nicotine replacement by calling them up and saying, program, and please send the free nicotine replacement. The other part of the intervention which was important is the application of what I call a behavioral shaping paradigm. So this was based on a previous study that I did, which I believe I referenced at the bottom. Yes. So the idea was that rather than what most smoking cessation programs do, which is once they get a referral and get a commitment from somebody to join the program, they say, okay, we'll join the program, come in, we'll give you an orientation, or call us up, we'll give you an orientation. Okay, you're going to quit smoking tomorrow, and here's your NRT. Slight exaggeration, but a lot of programs do that. What we do is we know that it's a challenge to get people to quit smoking, and even more so in this population. So what we do is we focus initially in the first few weeks on behaviors that are a little bit easier to accomplish. And we focus on child health as the primary focus and protecting children from secondhand smoke. So the first couple of weeks focus on if they're smoking everywhere in the house, beginning to limit the places where they smoke, putting up smoking signs. Eventually moving towards smoke-free home and smoking outside with smoking jacket and fluffing your hair and taking the jacket off before you come inside so that you minimize the third-hand smoke. All of these things that are a little bit easier to do than the quitting part of it. And the idea is to build confidence, to get people to begin to self-monitor and do some of the basic fundamental parts of behavior change process. And then as they get to the 3rd, 4th, and 5th week, we talk about how everything they've been doing prepares them for quitting. We try to boost their confidence and their readiness to quit. They set a quit day, and then we try to help them quit and move on from there. This is just a snapshot of the food for thought intervention. It was we tried to have comparable levels of contact with them. They received 2 telephone calls in 3 months. A lot of it was just focused on nutrition education. So now we get to the results. And does it look like I have about, I'll try to wind this up in 5-10 minutes. So at the clinic level, what we found in the 2-year enrollment period, we had 334 providers who made almost 3,000 referrals to the trial. Now, I can't go into a long explanation, but we were not able to do a pre-post test of the clinic level intervention, unfortunately, but we did track the fidelity of the AAR adherence by the parents' report when we screened them. So every parent that was screened, we would ask them what they learned from their provider to get a sense of how they were doing, how the providers were doing, and we would offer feedback to the providers with ongoing booster sessions. We also offered them feedback in terms of successes that the parents were making, like, oh, well, patient Johnny's parents have made their house smoke-free, so that was a way to keep the providers engaged. In any case, obviously everybody that was referred had been asked in the clinic about their smoking. Parents reported, about 84% of the parents reported that they were advised about prohibiting smoking in the car. 80% were advised about the benefits. And when it came to the referral, only 51% of the parents reported that they received a brochure, which we found out in one of the booster sessions at Temple, I believe, that some of the nurse practitioners misunderstood and were only giving the brochure to people that were not interested in our trial. So we cleared that up about a third of the way through the trial. But the good thing was that at the orientation session, we provided everybody with another brochure just for this reason, in case they didn't get one in the clinic. So everybody in both conditions were getting this EPA pamphlet that described how to. We randomized 327 parents. This is the quick profile, which illustrates that we were successfully recruiting from predominantly African American low-income communities in Philadelphia. About half of the parents lived in smokers with homes with other smokers. 13%, interestingly enough, at baseline reported having a total indoor smoking ban. So there was some effects of some of the public policies that have been occurring in Philadelphia, at least in some of the homes at baseline. Children ranged from newborn to 11. The average age was 5 years old of the children. Their baseline cotinine was 34.84, which is a pretty elevated level of cotinine. And for the analysis plan, we used intention to treat and complete case analysis with sensitivity analyses, which showed that there were identical substantive conclusions drawn in both types of analyses. We clustered for the 3 hospital systems and controlled for the standard controlling variables such as like nicotine, other smokers in the home, some of those things at baseline. And then I have about 5 slides that show the results. So at baseline, you see that there was no difference between groups in terms of the percent of parents that were reporting smoking restrictions in the home and car. But we see that at end treatment, there was a significantly greater number of parents in the multi-level KISS approach that were that had smoking restrictions in their home and car compared to the control condition. there was an increase in both. So they were getting some education from their provider, possibly from the brochure and other sources. That was an odds ratio of 6. So roughly 6%, or people in the KISS condition were about 6% more likely to adopt indoor smoking restriction. We also wanted to look at parents' report of eliminating all sources of exposure as measured by cigarettes smoked per day or cigarettes exposed per day to the child. We see that there's no significant difference at baseline, but at EOT, significantly more parents in the experimental condition had reported that they had totally eliminated all sources of secondhand smoke compared to 28.8%. One thing I was interested in looking at was were there any differences in quit attempts? The fact that about 65, roughly in the whole sample, 65% were reporting that they had at least tried to quit smoking and had at least one 24-hour period of successful abstinence suggests that the boosting of the motivation to make a change that was occurring at the clinic level was having an impact on both groups. But then when you look at 7-day point prevalence abstinence at the end of treatment period, there was significantly more people in the multi-level condition, suggesting that they were receiving types of skills training, individualized support and coaching, and that was having a difference, making a difference in the quit attempt. The 7-day point prevalence abstinence was consistent with prolonged abstinence. Moving through, one thing that was interesting too was we see that people in the control condition were calling the quit lines. So at the back of the brochure that we gave them was the quit line information and information about how to access products. So people in the control condition were responding to that. Again, that was dominantly as a result of the clinic level intervention. So there's a lot to be said for pediatric clinic level intervention in addressing this issue. And we see that there was no difference between groups in terms of reported use of nicotine products. The one thing I do want to say about nicotine replacement products was that just giving navigation and suggesting where to get, coaching them on where to get nicotine replacement turned out to be not enough. People, even in the experimental condition, were not using nicotine. Even though there were more people, significantly more people in the treatment condition than the control condition who were using nicotine replacement products for more than 2 weeks, the average, the median usage was less than 7 days. So they were not using nicotine replacement products despite the physician's advice and our efforts. And then we took a glance at, we haven't written this paper yet. The data I just showed you is under review at Pediatrics. We're waiting for that to get published before we do a formal mediation analysis, but we were eager to see what's happening. So we took a peek at some of the key hypothesized mediators, and it looks like the intervention, the KISS intervention, having an impact on the degree to which parents are using coping skills to manage their urges to smoke, and it's also building their self-efficacy or their. So this might be important information as we move forward to beef up strategies that can improve people's confidence. So it looks like both interventions did a good job in increasing motivation to make changes. But this multi-level approach that was designed to not only augment some of the health messaging that the pediatricians were giving through similar types of health messaging and counseling, the addition of the skills training and additional support and problem solving that counselors were able to provide really enhanced the ability to quit above and beyond simply brief advice, motivation. And then in summary, the The other trial that we're working on that we just started enrolling about 6 months ago is the babies living safe in smoke. What we're doing is we're translating what we did in pediatrics to community WIC clinics and trying to address postpartum smoking in particular, just smoking among moms in low-income environments. And what we're doing in there to overcome some of the shortcomings in the KISS intervention is we're actually giving them NRT. So when they enroll in our program, we give them the NRT, and then we encourage them to use it so we don't have to put so much energy into it. And then the third thing we're doing is we're building in multimodal strategies. So we took the NCI QuitPal app and we modified that to supplement our counseling in a couple of ways. One is by just augmenting the messaging that we provide in counseling, but we also have what we call a back-end counselor dashboard. So when the person is using their app, the counselor can see at their workstation each of their clients' input with respect to how many cigarettes they've smoked, what their triggers are, were their children present when they were smoking, what their moods were, what their coping strategies were when they were experiencing her. It's useful information to have in preparation for a phone session. We also have some other multimodal strategies, but the idea is trying to build messaging and fill gaps in support that occur in between phone sessions. So we'll see how that turns out. I'm hoping that, especially with the NRT, we're going to be able to make a bigger impact. If we can increase the uptake of NRT in this population, I think we'll see much. So I'll stop there. Wanted to just recognize all the other folks, the students that work with us. But that's all I have to say, and I apologize. We have maybe about 5 minutes, but I'm happy to stay as long as you guys want. Yeah.
This is great work. Thank you for presenting it. As part of giving up smoking, I'm thinking of where you have, particularly in younger adults, you may have a switch to using e-cigarettes and vaporizers, and that you could still have the exposure then to whatever byproducts are in them. Did you look at that? Was that part of your analysis to consider? Even though they have less tobacco exposure, there may be more of an increase in other exposures.
Right. Yeah. So it was interesting. So when we designed the study and started the study, we didn't think about e-cigarettes until probably a couple of months into it as we were talking with the participants. So we started adding some ancillary questions about e-cigarette use, exposure. A fascinating area, one that I want to dig more into. And we ask a lot of those questions in the current study with the WIC moms. So there is a decent degree of e-cigarette use. We also, as far as our counseling, we encourage, we drill down and get a sense of, okay, you've quit smoking, but have you quit all tobacco products? We make sure that we're assessing the quits appropriately. We also are tracking the exposure to e-cigarettes and advising about the dangers of e-cigarette exposure as well. There's heavy metals in e-cigarettes. Children are still getting exposure to nicotine through the vapor that's expired into the air. But it's a fascinating area to get into, particularly with a lot of the myths around the safety of e-cigarettes.
I think I missed it. How long was the intervention?
I'm sorry?
How long is the intervention?
Intervention was, it was over 3 months. So they received up to 5 calls over a 3-month period. Same kind of approach with the Bliss study, but we interject with text, push cartoons to them that, like cartoon clips that drive some of the messaging. But in the KISS intervention, it was simply the phone calls, some retention.
So the analysis that you showed is a 3-month analysis. It's the end of intervention analysis. So the 6 months will show then the retention and how patients are.
Yeah, so our retention was actually pretty good. We, by the end of treatment, we had, it was 86, 12 month follow-up. We had 8%.
I was more thinking about recidivism and
oh, right, as far as like adherence.
Right, adherence.
Right.
After treatment, once the treatment has stopped, once the intervention has stopped.
Oh, right. Yes, we're learning that now as we're looking at so we just completed the 12-month data and we're starting to look at it. Yes, and I do want to say that, you know, with the KISS intervention trial, when we got funded with it, like many of you are aware, like a 20% budget cut. With that 20% budget cut came a cut in our bioverification. So all of the data that I presented here, the big limitation is there's no bioverification. We have that at 12 months, so we're eager to see not only what the recidivism or relapse rates were, but also in particular the child exposure rates. Now there's, you know, we used valid timeline follow-back methods for getting the self-report, which is to be reliable, but, you know, our data would be strengthened with bio. But yeah, so we're interested in that. There's, you know, undoubtedly going to be a drop-off in. Just it always happens.
Why only 2 weeks of that path? Is it budget constraint or is the starter kit? The replacement kit?
Yeah, well, for KISS, we just didn't have the capacity to do it. But for the current project, we do provide a full 8 weeks of. And that follows the emerging standard of care in quit lines across the country, where they'll provide a 2-week starter kit, but they'll give 8 weeks to people that either don't have insurance to cover it or can't get it free through some local service. So since all of our people are low income, we just budgeted for 8 weeks. But I have to say, just anecdotally, with the new study, we still are having a hard time getting people to use NRT properly. There's a lot of myths in the community about how to use it and the dangers associated with using it that are really hard to overcome. But I think that's probably the biggest obstacle in really seeing strong quit rates, state of the art in these populations, because there's so low rates of uptake.
Well, thanks so much.